Welcome to this discussion on middle age and vision correction surgery. It's quite scary for many patients when they get to their middle age because they find they can't read up close anymore. As they get towards 50, many patients find even the distance starts to get more difficult, and certainly reading has gone. Most patients are concerned that there's something wrong with their eyes. In actual fact, sadly, it's just the passage of time. Your eyes are getting older and the lens inside your eye is failing to accommodate or flex or allow you to see up close. So the first port of call is usually your optometrist or your eye specialist, just to check that your eyes are actually healthy and that all you're suffering is the middle-aged onset of reading difficulties, which we call presbyopia. So patients turn up to see me and they're concerned, and after I've told them their eyes are normal, the next question is, what can you do about it? Obviously they're concerned and they want some sort of surgical solution. Generally speaking, they can wear glasses, but if they want something permanent, then we're talking about either laser vision correction or lens implantation or clear lensectomy. I'll describe the merits of each to you shortly, but in either case, you have to always remember you're doing a surgical procedure on a healthy eye, and there will always be some small risk. And therefore you have to consider whether you want to have surgery or whether perhaps you should stay with the glasses. As a general rule, for patients over 50, I prefer clear lensectomy, which is removing the crystalline lens from the eye. Laser vision correction for long-sightedness in the 50s tends to wear off, and the vision quality tends not to be quite as good as a lens implantation. And furthermore, you still have the lens in your eye, the original lens, which is aging with vision quality which is reducing. In many ways, removing the lens from the eye, or a clear lensectomy, kills all those birds with one stone. You remove a future cataract, you have the best possible quality of vision, and it remains permanent for a much longer time. Obviously, it's a little bit more invasive of going inside the eye to do the surgery. So, you've decided you want to have some surgery, and let's say you're going to have a clear lensectomy. You then have some decisions to make. What is it you're trying to achieve? Do you want to have good distance vision in both eyes? Would you prefer to have one eye long and one eye short? We call that monovision. The dominant eye is made distant and the non-dominant eye is made short-sighted for reading. Now, many patients hate this. They hate the unevenness of the eyes. They feel their depth perception has been thrown out. They have difficulty driving, and some of them have difficulty reading. And I think 50% of people probably fall into that category. But for the other 50% of people, their brain is suitable and it suits them just fine. They're able to separate the images, the distance and the near, and they proceed quite comfortably. This is called monovision. The good thing about monovision is it's reversible with a pair of glasses, and it's rehearsable. You can try contact lenses to see what it's like before you do it, and for that reason it's probably my preferred option. However, there are some patients that don't want to have that difference between the two eyes, and they may choose to have what we call multifocal lenses. Multifocal lenses give you vision from the distance all the way up close, but they do come with some side effects. So if you're feeling a little braver, you might like to talk about a multifocal lens. The side effects many patients experience include starbursts, with lines radiating out from headlights or point sources of light, and you might notice that yourself when you look up at the light. The other problems they notice are halos, rings around lights. Generally speaking, 90% of people are okay with it, but 10% of people really hate it. For me, 10% is a little bit too high. I don't want to worry that 10% of my patients would have these side effects to the point where it would cause them a lifestyle concern. And for that reason, I tend to shy away from multifocal lenses unless a patient is very keen, understands the downsides, and is quite motivated to make it work. And for those patients, it really can work very well. Okay, you've made the decision you want a multifocal lens. Now you have to decide whether you want a high impact multifocal lens or a low impact multifocal lens. The high impact multifocal lens will give you better reading vision, but it comes with more of those side effects I mentioned. The lower impact multifocal lens won't give you quite as close a reading vision, but it does come with lesser side effects, and you have to work out which of the two things you're willing to trade off. In general, I find most patients, 90% of people, really hate it. For me, 10% is a little bit too high. I don't want to worry that 10% of my patients would have these side effects to the point where it would cause them a lifestyle concern. And for that reason, I tend to shy away from multifocal lenses unless a patient is very keen, understands the downsides, and is quite motivated to make it work. And for those patients, it really can work very well. Okay, you've made the decision you want a multifocal lens. Now you have to decide whether you want a high impact multifocal lens or a low impact multifocal lens. The high impact multifocal lens will give you better reading vision, but it does come with lesser side effects, and you have to work out which of the two things you're willing to trade off. are interested in spectacle independence, meaning that they just want to be able to do some things up close. They don't have to read a book for 2 hours at a time, and they're usually happy to wear reading glasses for those times. But in their daily life and their social life, they want independence to go out without their glasses, to be able to use their mobile phone and to be able to open their wallet and pull out coins and know which is which, and to be able to go to a restaurant and look at a menu. Those sorts of things are quite achievable with the low impact multifocal lenses, which will give you fewer side effects. Putting aside multifocal lenses for a moment, I'll go back to say that my preferred option is the Monovision, the one eye short and the one eye long, because in the patients that have this done, if they are struggling with the difference between their eyes, they simply wear glasses and make it go away. It's quite reversible. If in fact they get used to it, they permanently stay with their Monovision and they're quite happy, some of them just using glasses for driving. As you can see, there's a lot of thought to be had. There are a lot of decisions that you have to make, and ideally you have to sit down with your eye surgeon and decide what suits your lifestyle, what potential risks you're willing to take, and what side effects you might be willing to put up with. It's not an easy discussion. It has to be individualized, and you have to look at your lifestyle, and I would have to look at your lifestyle to determine which suits you best. I hope this has been helpful. It's a difficult and complicated topic, and generally speaking, the more you search the internet, the more confused you'll get. I hope this has been of some help.